On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled Update on Clinical Guidance for Surgical Fire Prevention and Management. My name is Melanie Moss, and I'll be your moderator for this program. Now I'd like to introduce our speaker for the webinar. Mark Bruley serves as the Vice President for Accident and Forensic Investigation at ECRI Institute and is a certified clinical engineer. He started working at ECRI in 1975 as a project engineer performing comparative evaluations of medical devices and investigating medical device problem reports. Since 1982, he has developed the Institute's Health Technology and Medical Device Accident and Forensic Investigation program. He has published more than 165 technical papers and book chapters and is active in many professional societies, standard committees, and patient safety initiatives. Over the past 35 years, many agencies have relied on Mr. Bruley on his expertise on surgical fires, including professional medical societies, the Joint Commission, state departments of health, and the FDA. Mark, now I'll turn the program over to you.
Thank you, Melanie, and good afternoon to all of our PSA registrants and listeners for this webinar on surgical fires. And I will update you on the clinical guidance for its prevention and management. So let's begin. What we'll be focusing on today are a number of issues. First, understanding how many fires are occurring in Pennsylvania, and as that's scaled to the United States, how many are occurring there. It's important to understand how that fires are still occurring, so when you are talking with administration to get their buy-in to support your educational initiatives, that they understand that this serious, albeit rare hazard is still going on. You'll find out which surgical devices and materials are flammable and how they might get ignited. Also, recognizing the severe issue of oxygen-enriched atmospheres that build up under surgical drapes and towels. The recommendations on how to minimize the chance of fire I'll present in 1 or 2 slides from now, and then repeat them at the end, and we'll be going through them individually. And you'll then also know how to extinguish a fire that's burning on a patient or burning inside of a patient's airway. And finally, what type of fire extinguishers are best for inside of each OR? Not the core, not the hallways, but in each OR. We'll be discussing that as well. So the current guidance on preventing surgical fires focuses on eliminating the buildup of oxygen during sedation of surgery that takes place essentially above the xiphoid, the head, neck, base, and upper chest. Second, that if supplemental oxygen is needed for a patient, for example, under MAC anesthesia, monitored anesthesia care, that you should be securing the patient's airway if that increased oxygenation is required. We'll talk a lot more about that. Finally, although it should come first, using a pre-op timeout to assess the fire risk can be a very straightforward task that doesn't take up too much time, but does repeatedly sensitize the operating room staff to the fact that a risk may be present and then what you as a team will do about it. A brief history as it relates to surgical fires is that up until 1980, we were using flammable anesthetics, and everyone knew it was a risk. It was known and feared that there could be a fire or an explosion based on the flammable anesthetic. Since 1980 until present, it's been an insidious, a hidden hazard, specifically related in most part to oxygen enrichment underneath the drape. Alcohol prepping agents have undergone a resurgence over the last 20 years or so, and alcohol-initiated fires during surgery certainly get a lot of attention, but the reality is they're only about 4 or 5% of the fires that have happened. Everyone knows that alcohol is flammable. They don't know as much about the fact that oxygen enrichment under the drapes makes many other fuels extraordinarily flammable as well. Also, the insidiousness of this has been related to poor recognition by clinicians and hospital administration that this is a risk that needs to take, of which they need to take note. Previously, there had been no collaboration among stakeholders, and unfortunately, and this is a frustration on my part as an engineer and scientist, that we do not have any technological remedies to solve this hazard that you within the clinical community have to deal with. Back when we were using flammable anesthetics, there were anti-static precautions to prevent static electricity buildup, since a static spark could just ignite the flammable gases. A static spark cannot ignite an oxygen-enriched fuel, but aside from that, we don't have any way to minimize the flammability of the fuels in the surgical setting, because it's really all about the oxygen. Within the Pennsylvania Safety Authority's databases and in the advisory that they publish routinely, some years ago, they published the never complications of surgery. And the top three were retained instruments, wrong site surgery, and surgical fires. And we've been dealing with surgical fires and assessing the number of fires that occur, the incidence, since 2004. And from 2004 to 2007, in our assessment back in the PSA advisory, we saw that there were about 28 fires per year in Pennsylvania alone. When ECRI Institute scaled that data to the United States, there were about 600 fires a year. Most of those were minor, but 20 to 30 would result in serious or disfiguring incidents on the patient. We updated that study 5 years later in 2012, and we fortunately found there were now only 10 fires per year in Pennsylvania based on 7 years of data. When ECRI Institute scaled that to the United States, we were down from about 600 to about 220 per year. Again, mostly minor in ECRI Institute's estimation, with still 20 to 30 being serious or disfiguring. And now the great news. We have recently updated the 2012 study, and this will be published in the advisory in the coming months. And there are even fewer fires now based on what I'm assuming are all the good initiatives, certainly within the Commonwealth of Pennsylvania. We are now down to 5.6 fires per year in the Commonwealth, which since 2004 is a 71% reduction in the number of fires. And if that trend continues, then in the academic year 2031 to 32, we will reach 1 fire per year in Pennsylvania. Currently, with the new data, we are down to about 90 fires per year in Pennsylvania, or 90 fires a year in the United States, as ECRI Institute scales that across the board. The initiatives for all this have come from certainly ECRI Institute, but the professional societies as well, from the anesthesia group, the Pennsylvania Safety Authority to be sure, the operating room nurses, American College of Surgeons, Joint Commission, FDA, and you might not have thought it, but the electrosurgical unit manufacturers have updated their guidance, recommendations, and educational initiatives as well. So all this has really taken place pretty much since about 2004 or so, and we have a lot to be proud of across the board in regard to all the initiatives to minimize surgical fires. The PA Pacers and the advisories has published a variety of issues on surgical fire prevention. You can see the list here, and had previous webinars that we've presented on this topic to maintain awareness within the clinical community. Moving to where these fires happen on the body, you can see that a majority of them happen in head, neck, face, upper chest, and the airway, and the airway is certainly part of the head and neck. About 26% were elsewhere on the body, and this is ECRI Institute data, and about 8% elsewhere in the body. Importantly, 70% of these involve oxygen enrichment, and typically from open oxygen delivered on the face, either with double-pronged nasal cannulae or with a disposable oxygen mask. And the types of procedures during which they occur are numerous. You can see the list here. I won't go through them individually. I could do an M&M conference on any one of them for a half hour. But the sensitivity of clinical staff and support by the clinical educators and administration for that educational initiative is needed, since these fires can happen almost anywhere on the body. Also, as I've put it, surgical fires put a new face on patient safety within the news media. These are pictures used with permission of the patient of women who had undergone head and neck surgery and were set on fire. That is not the type of, and those pictures were from the lay press, the lay media. That's not the type of publicity that any institution wishes to have. Some of you may have seen me on Good Morning America the morning after Thanksgiving, interviewed by Gio Benitez on the topic of surgical fires. The link to that 5-minute been DMA fire surgery, and it should just pop up as a video. Over the decades, there have been many publications about surgical fires in the risk management literature, the professional society literature for nurses and anesthesia, and some for surgery. The Head and Neck Surgical Textbook by David Isley and Richard Smith has a chapter in it, both in the initial edition in 1998 and the updated edition in 2016. It's my chapter in there on surgical fire prevention. And the 2009 October edition of Health Devices, which is ECRI Institute publication similar to Consumer Reports for consumer products. The entire issue in October 2009 was on surgical fires. A little bit more history as it relates to Joint Commission, because in the past, for 5 years, the Joint Commission had as a patient safety goal the topic of surgical fires. And for those of you unfamiliar, what happens with a patient safety goal is that is one of the things upon which a hospital is judged during a Joint Commission survey. You are graded on it. And there were issues about educating staff on heat sources and managing fuels, but importantly, they dealt with minimizing oxygen buildup under the drapes, and even more importantly, the hospitals were required to educate independent licensed practitioners and anesthesia providers, not simply the staff who were employed by the hospital itself. There are a few misconceptions published within the surgical community that we need to deal with, and we've subsequently addressed these in publication. But the Bulletin of the American College of Surgeons in 1998 had published that you should buy fire retardant drapes. They don't exist. You cannot make them because it's all about the oxygen. There's no technology that can render a fabric, either natural or synthetic fabric, non-flammable when you have oxygen concentrations of 40, 50, 80, 90% in and around that. DuPont said they can't make it for NASA, and they certainly can't make it for the healthcare community. The American College of Surgeons had also published that betadine skin prep was flammable. It is not. It's water-based. They said that when your patient catches fire, you should get a fire extinguisher as the first thing to do. That's impractical, especially in an oxygen-enriched fire. And they said that fine body hair on a baby, the lanugo, is highly flammable in air. It is not. These were all misconceptions that are fortunately dropping by the wayside. So as a clinical team, how do we go about preventing surgical fires? And the prevention does rely within the team itself. ECRI Institute, in collaboration with the Anesthesia Patient Safety Foundation, published for the 6th time in 2009, and this poster is still current in regard to its recommendations. Our poster that summarizes the research and recommendations, all of which are peer-reviewed, that have been under development for many years. We first published this in 1979 as a shorter version of a poster. And I'll go through, not word by word, but I'll go through the highlights of this poster as we go through. Within the realm of educational initiatives, the Anesthesia Patient Safety Foundation at apss.org produced and published a video in 2010, and again, it's still current, on how to prevent surgical fires, prevention and management of OR fires. ECRI Institute produced that for APSF. I directed that production, And it addresses the issue of unquestioned use of oxygen on the face, how to blend oxygen with air for a safer concentration delivered to the patient, how to drape the patient, fires were recreated, and how to extinguish them were all addressed on that video. I highly recommend going to apss.org, looking at the video, incorporating it into your educational program. It's available free as a DVD, or you can download it free from the internet. It lasts about 15 minutes, and it is still current in regard to all its recommendations. It's important to recognize that it's a transdisciplinary challenge to prevent fires in the surgical setting. Different staff have different responsibilities at different times when we're in the perioperative setting. It's important to assess each individual patient's acute needs for open oxygen on the face versus the risk of a fire that may occur. Now, continuing education is needed, but it's not a panacea. It's not a total preventive to getting rid of surgical fires. The real issue is making everyone aware of it on a routine basis. Although the number of fires is decreasing, fortunately, due to initiatives on all of your part, they are still happening, and we can no longer accept that surgical fires might be unavoidable. In high school and perhaps in college, you've heard about the fire triangle. And here it's shown with surgeons at the top, anesthesia professionals at the bottom left, and nurses on the bottom right. So at the top, you see a Bovie pencil, an electrosurgical pencil, as the ignition source. We also have surgical lasers and hot wire cautery pencils as an ignition source. And they're usually under the control of the surgeon, but they may also be under the control of the scrub nurse who's handing it to the surgeon or taking it from the surgeon to put it in a safe place. The fuels, such as the surgical towels, prepping solutions, and drape, are handled, again, both by surgeon and nurse at the beginning of the procedure. The oxidizers are handled only, for the most part, by the anesthesia professional. And nitrous oxide is included as an oxidizer, but we usually don't use that in an open fashion. So we're pretty much talking about oxygen delivery during the perioperative setting from an open source on the face. So what is this hazard about oxygen? I've mentioned it several times. It's all about the oxygen. Oxygen doesn't burn. Oxygen is, by definition, the oxidizer. It makes other things ignite at much lower temperatures and burn much faster and much hotter. At ECRI.org/surgical_fires, which is our free clinical website for surgical fire prevention reference information, we show a video from the 1960s made by the British Royal Air Force about surgical fires. Back then, they had experienced fires in the flight crews who would come out of working on a fuselage of an airplane, and they would come out of the fuselage, walk across the hangar, light up a cigarette, and they were bursting into flames, even though they were not dealing with any fuels. Pure oxygen is slightly heavier than air, and it will form an invisible cloud that either wafts down across your body if you're in a seated position, or will build up and waft down on off the sides of the table underneath the surgical towels and drapes. And what the Royal Air Force did was to take mannequins and dress them in cotton flight suits, cotton just like the towels that are made of pure cotton, the green or bluish towels in surgery. And then they used a hot wire igniter similar to a little battery-operated cautery pen. And they triggered a fire on the surface of the fabric. Now, I'm going to pulse through the speed with which the fire spreads across the fabric, and it's about like this, winding up with a fire like so. I'm going to go through that again. The rapid spread of fire across the fuzz on a towel or across the patient's hair is due to a propagation. Right? published an article and presented a paper at a NASA conference back in 1989. And what happens is that each little fiber sticking up from a cotton towel, body hair, like peach fuzz, that's in the middle of your forehead, or it's on the underlayment of hair on a man's chest, or it's on a woman's chest as well. That is called vellus. And the vellus, tiny hairs, or the fuzz sticking up off of the cotton towel, each little hair or fiber will burn as a miniature sparkler and igniting the next one and the next one and the next one in that propagating flame front that will go right across the surface of the fabric at a speed of about 10 feet per second. And that's head to toe in less than a second. And in the surgical setting, you would wind up with a patient that would be on fire in and around the head and neck surgery area. Again, you can see that in real time in the video at the ECRI.org/surgical_fires. So prevention, again, lies within the team. There are also other educational initiatives that have taken place by the Association of Perioperative Registered Nurses, AORN, as well as the Anesthesia Patient Safety Foundation that has a fire prevention algorithm that can be used during the pre-op timeout. And the American College of Surgeons updated their previously incorrect recommendations back in 2013. So in talking with administration and focusing on the fact that this is an issue that needs their support and buy-in, telling them that the nurses, the anesthesia professionals, and the surgeons in their professional communities are all bought into recognizing that surgical fires are a real risk, albeit rare, and the hospital needs to take action to make sure that some initiatives on an annual basis are instituted to keep it sensitive, or to keep the sensitivity and awareness present within the surgical team. And doing that as part of a pre-op timeout is one way to deal with that. So the current guidance deals with controlling the airway to prevent oxygen enrichment and buildup underneath the surgical drape, controlling the heat sources, which you're probably already doing, such as using holsters for the electrosurgical pencils, as well as putting lasers in standby when not in use. By the way, ophthalmic lasers have never been involved in a surgical fire. When we talk about lasers, we're only talking about general purpose lasers. And controlling fuel, such as alcohol, making sure that it's not applied in a sloppy fashion and that it does not build up underneath the surgical drape. And again, communicating both in the pre-op timeout as well as during the surgery. These are addressed very nicely in the APSF video into how to deal with the communication aspect. Now, I'm always suspicious of any patent recommendations that say you can't ever do thus and such. So when these recommendations were developed in regard to preventing oxygen buildup under the drapes, there has to be some exceptions, and I'll go through those in a moment. For the pre-op timeout, it's best to identify and assess the fire risks for that individual patient and determine whether use of an open oxygen source on the patient's face is needed. If it is needed for what we call an exceptional case, then how do you minimize the risk of fire? And you would discuss this, and we'll go through those bullet points that are on the poster. And in regard to alcohol-based skin preps, if they are being used by the OR, the scrub nurse, and the surgeon, or by the anesthesiologist, if they happen to be doing a cut down on a subclavian vein or a carotid artery, they may be using an alcohol-based prep. And if their prep by the anesthesia staff is not done carefully, then there may be latent alcohol underneath the back of the patient's neck or the shoulder that the surgical team may not be aware of. So the issue of making sure that alcohol-based skin preps are dry applies to everybody on the surgical team. The Christiana Care healthcare system in Dover, Delaware, or in Wilmington, Delaware area, published a rubric for doing a surgical fire timeout and assessing a patient's risk for surgical fire. The website to link to that is at the end of this presentation. So, in regard to preventing surgical fires, communication is certainly essential, and each of these recommendations has to be assessed individually for each patient. There's no one patent set of recommendations that can apply to everyone. So at the beginning of surgery, we have to, I want to focus on a few things. Recognize that the oxygen is flammable, or the oxygen will make other things highly flammable, and you shouldn't drape until all the preps that might have alcohol in them are dried, and there are other bullet points there as well, including moistening sponges to make them non-flammable if you're doing oropharyngeal work. Now, during the head and neck surgery, only use air for delivery to the patient's face if that patient can sustain their pulse oxygen saturation. To apply oxygen to a patient's face without assessing the need for that patient is the only instance that I've ever come across in healthcare where a drug, in this case oxygen, is provided to a patient without assessing just how much drug that patient needs. There's no other drug that you would do that on. The reason that pure oxygen has been routinely delivered to a patient is that it was so conveniently available on a flow meter on the side of the anesthesia machine. So that's why, in our opinion, the oxygen was building up under the drapes, resulting in a significant incidence of surgical fires since the mid-1980s. There's a bit of a paradox here in that the advent of pulse oximeters, in our opinion, also contributed to surgical fires in the following way. Since we could now very easily measure a patient's blood oxygen concentration, there was an impulse to maximize it, whether it needed to be maximized or not. A 19-year-old patient with a piece of pencil lead in his eyebrow probably doesn't need to have pure oxygen on his face. However, in a case that I investigated, he had pure oxygen, his face was set on fire, he didn't need it. Lack of communication between the surgeon and the anesthesiologist, who had recently broken off dating, contributed to all this. It was also more complicating that the child was the son of one of the members of the board at this large university-based educational institution. So to the extent that you can use air only on the patient's face, underneath the drapes to keep things fresh, that should be considered. So, use only air if you can maintain the blood sats without supplemental oxygen, and if you can't, then secure the airway with a laryngeal mask or a tracheal tube. Within the anesthesia community, these were great deviations from the standard practice that had been employed before, sort of without question, of just providing oxygen on the face. But now, using a laryngeal mask or a tracheal tube for what previously would be just considered minor surgery is what is indicated if that patient needs supplemental oxygenation. That way, you do not build up oxygen under the drapes, and when you're in the head, face, neck, and upper chest area doing surgery, you can wind up you will then minimize the risk for fire. Of course, there are exceptions, as I mentioned. If you're doing surgery where a patient needs to verbally respond and needs to have supplemental oxygen, such as carotid artery surgery for an endarterectomy or neurosurgery or pacemaker insertion, there are nonetheless ways to minimize the risk of fire on that patient. And the 9 items here under this bullet list for the exception focus in a large part on oxygen delivery. You can begin with 30% oxygen by blending it through the anesthesia machine or through an oxygen air blender. It's only in the last few years that the anesthesia community has even found out what an oxygen air blender is. Those of you with any respiratory therapy experience deal with these all the time. It's a small box that can fit right on an IV pole, and you provide it with air and oxygen, and you simply dial on a single knob what concentration you want to come out of it. At 30% oxygen, you do not have the hazard of a flash oxygen-enriched fire that I demonstrated in the black and white video. At 30%, you do not. So if you can get by with 30%, that's where you would start. And remember, you're also monitoring the patient's pulse oximetry to see whether or not they are desaturating. There are other bullet items there on how to minimize the risk for the exceptional cases. Go through these with your anesthesia staff and with the surgical staff and understand which ones may be best applicable for the exceptional cases. All of this presumes, however, that you've done an assessment for that individual patient and that they are, in fact, an exception where they need to have open oxygen on the face. During tonsillectomy, it's been recommended to scavenge deep within the oropharynx with a metal Yankauer suction cannula, not a plastic one, because the plastic ones can and have caught fire down in the back of the throat. Also, moisten the gauze or the sponges and then wring them out and use those to soak up the blood, such as during tonsillectomy or other oropharyngeal cases. During bronchoscopic surgery, I'll get back to tracheostomy in a minute. During bronchoscopic surgery, if the patient needs supplemental O2, then again, try to keep the concentration below, at or below 30%. Because what would typically catch fire inside the bronchus is the end of the bronchoscope, or you may get a flare-up of tissue that's being cauterized, and that flare-up in higher oxygen concentrations can again then ignite the end of the bronchoscope. As far as tracheostomies are concerned, it's important to understand that the way to prevent a fire during tracheostomy is to minimize the use of electrosurgery to actually enter the trachea. You do not want to do that, because that can be fatal. What can happen during tracheostomy is that since you have 100% oxygen inside the trachea, you can wind up accidentally igniting the tracheal tube or the cuff, and I'll show you a case review of that in a moment. You should only use electrosurgery to cut down to the trachea, but then scalpel or scissors to go into the trachea. We have many ignition sources that are present, including fiber optic light cables, surgical lasers, hot wire cautery pencils, Bovie. I show the defibrillator paddles there as well, because if you do have to defibrillate on the outside of a patient's chest with oxygen flowing, then that can ignite the patient's chest hair. Perioperatively, that's rather rare, but sometimes it has been happening. The brightness of the surgical lights usually prevent you from seeing the fact that sparks can fly off of the operative site. Here we're cauterizing calf's liver in the presence of oxygen, and sparks can fly up to a couple inches from the target tissue. And if a spark alights on a surgical towel, which is oxygen enriched, then that spark can then ignite that towel. And the fire will then spread like the ripple of flame shown in the black and white videos, but instantly across that, igniting the patient's hair and other flammable materials, including the oxygen mask or delivery tube. With electrosurgery, colloquially called Bovies, or hot wire cautery or lasers, always be aware that the surgeon should always be made aware if open oxygen is going to be used. And again, that would be through communication within the operative team during the pre-op timeout. That would be brought to the surgeon's attention at that time. The unit should only be activated when the surgeon can see the tip with his or her eyes, especially if the surgeon is operating through a microscope. It should be deactivated before the tip leaves the surgical site. Lasers should be put in standby mode when not active, and please do not put red rubber catheters over an electrosurgical electrode to make them better insulated. If you do that, you are modifying a medical device, and that red rubber catheter is not a very effective electrical insulator at the extremely high voltages that come out of a Bovie tip. Plus, it's very flammable, especially in an oxygen-enriched atmosphere. So if you want better insulated electrosurgical electrodes, buy them. Don't make them. As far as extinguishing is concerned, if the fire is on the patient, the recommendations are to stop the flow of all gases to the patient as you immediately rip what's burning off of the patient. If needed, with the materials that are thrown to the floor, or if we know of only 3 cases in 40 years, if the fire is still burning on the patient, use a CO2 fire extinguisher to put out that fire. You would then care for the patient and, as necessary, quickly notify the front desk in the OR that a fire has occurred for which broader action might be needed. We know of no operating room fire that's ever gotten out of the operating room and affected anyone else in the other operating rooms themselves. Typically, if it's a very small fire, an instinct is to pat it out, either with a hand or to flip the drapes over. If it's a very big fire, you need to rip what's burning right off of the patient and throw it to the floor. This is very nicely shown in the APSF video on how to do this. For an airway fire, and by the way, I would stress again, these were peer-reviewed recommendations that have undergone extensive debate, especially related to extinguishing airway fires. If a tracheal tube catches fire, the first thing to consider doing is to remove the tube from the patient. If that can be done with item 2, which is stopping the flow of all gases to the airway, then that's fine. But it's essential to get that tube out of the patient and then to pour saline down into the airway and care for the patient. And here's why. When a tracheal tube catches fire, this is a PVC standard tube, it is literally a blowtorch burning down in the lung. And you can see on the top left picture that the fire is working its way up the inner channel of the tube, the lumen, but the cuff is still inflated. It has not damaged the cuff. When you turn the oxygen off in the lower left-hand picture, the remaining oxygen in the tube still fuels the fire, and that fire is pressurizing and the area in the lumen and is still shooting superheated gas and toxic gas into the lung. If you then re-administer the oxygen through that into that bottom left picture, you then get the top left picture again. The picture on the right is the actual tube from a case I did in Canada. It was a fatal case where they were doing a tracheostomy. They cut down to the trachea with electrosurgery, which was fine, but then the surgeon used the electrosurgical tip to cut through the cartilaginous rings of the trachea. In doing so, fire erupted out of the incision. The anesthesiologist instantly turned off the oxygen, and the fire appeared to go out. The patient was in end-stage COPD, so the anesthesiologist turned on the oxygen again, and for a second time, the fire erupted out of the incision. Of course, it's also blowing down toward the carina in the lungs, as you would see in the top left picture. They then turned off the oxygen for a second time and poured water into the incision. But since the inside of the tube is burning, the water is not going to get inside the tube. So for the third time, when they poured water into the incision, fire erupted out of the incision. They finally poured water down the tube, and that put out the fire. They reintubated. The patient died 2 weeks later from his trachea having been turned into charcoal. It's essential to get that tube out. If you can do it by popping off the breathing circuit at the tracheal tube connector, simultaneous with trying to get it out, that's fine, but the tube has to get out. Fire extinguishers. Inside each OR, we've been recommending, as has the Anesthesia Patient Safety Foundation, AORN, and others, to have a small, like 5-pound CO2 fire extinguisher. You do not have water, dry chemical, water mist, or fire blankets in each OR or in any OR. The only thing reasonable for discharging on a patient is CO2. The rationale for that are at our website. So the current recommendations really focus on eliminating open oxygen delivery during sedation or surgery of the head, neck, face, and upper chest. And if a patient needs supplemental oxygenation during otherwise called minor surgery or any surgery, that you would use a secure airway with a laryngeal mask or a tracheal tube. And during the pre-op timeout, assess the fire risks for the patient to determine whether there's any untoward risk, whether something special is needed to minimize that risk, especially for a patient that falls in the exceptional category where they need to speak during surgery. So the poster that is being presented and is one of the handouts for this webinar is a good starting point for your review of your policies and procedures. It's also available free at the ECRI Institute Surgical Fire website. And the 2009 Health Devices Citation is where these were initially published. We again recommend getting a copy of the DVD or downloading it from the Anesthesia Patient Safety website of their 15-minute educational video on how to prevent surgical fires. They have sent out more than 4,000 DVDs in the last 7 years. For more information from Patient Safety Authority, I have several hot links here that you can go to that were published in the advisory itself. And other resources are on this page from AORN, the Anesthesia Patient Safety Foundation, as well as related to the FDA initiative that was started in 2011 and then transferred to the Joint Commission in 2015 at that website. The Christiana Care rubric for doing a fire risk assessment, that website is shown there as well. As Smokey the Bear says, only you can prevent surgical fires. We don't have a technological fix to this. It's really all related to the surgical team.
Okay, thanks, Mark. That was a very informative presentation that contained valuable information everyone can use in their organization. This concludes our slide presentation portion of our program. Now we'd like to begin our question and answer period. Okay, I do have a question here, Mark. Says, we saw a fire start at the shoulder, but there are no ignition sources there. Oxygen was in use, but no alcohol prep. What could have caused that fire?
Oh, it's an interesting question. It relates to the surface fiber flame propagation in the black and white video clips I showed. If you're, for example, putting in a pacemaker and doing a pocket in the pectoral area of one of the breasts and delivering open oxygen underneath the drapes and the towels, then what can happen is when you cauterize at the incision pocket, the fine body hair can spread the ripple of flame across the surface of the skin, but it could be invisible based on the brightness of the surgical light. And it could then ignite the fuzz on the underside of the surgical towel and be directed over toward where the higher oxygen concentrations are. If, for example, the patient's head was turned to the left and it was the left shoulder that caught fire, you will have a higher oxygen concentration in and around the left shoulder. So it was likely oxygen-enriched ignition of the fine body hair that then spread to that fuzz that's on the underside of the surgical towel, which would then ignite the base fabric of the towel. Other questions?
Yes, I have another one here. In AORN video for fire prevention, it says to never pat a small fire to extinguish it, but to put a towel and sweep your hand across it.
It
Any
depends
comments on that?
I know that some educational initiatives have said to use a towel. However, the time it takes to get a towel and put it on there as opposed to flipping the drape up and patting it out with your hand can be the difference between a disfiguring fire and a fire that does not injure the patient. I had participated in the AORN fire prevention videos and their fire prevention kit when they did it initially in 2006 and then in the update. They don't say don't pat it out with your hand. They just say don't pat it out. Instinct typically takes over. And if you have a fire burning on the patient, getting it out as quickly as possible is the best thing to do. If you have to say, somebody quick get me a towel so I can pat this out or put a towel on it, those extra few seconds can be critical, especially if it's an oxygen-enriched fire. Given the speed with which those fires can happen. I suggest that you follow your instinct. If a towel happens to be available instantly, fine. Otherwise, you can flip up the side of the drape onto what's burning and gently pat it out. Just putting a towel on it and sweeping your hand across may or may not put it out. If it's an oxygen-enriched fire, you will have fire burning underneath that area as well, continuing to be fueled by the oxygen. And with an oxygen-enriched fire, the tiniest little ember that's still glowing will erupt into flaming ignition. So I understand why AORN was saying that. It's not something that I wholly agree with. What in reality happens is that the surgical team, in their zeal to extinguish the fire, will do what they think is most instinctive. And that may be, in many cases, to pat out the fire. Other questions?
Okay. Yep, I have another one here. Is a water extinguisher outside the OR antiquated? Should it only be CO2?
Outside the OR, use whatever you want. Inside the OR, only CO2. If you have water extinguishers in the core or the hallway, that's fine. But inside the OR, for what might be extinguished on a surgical patient who's on fire, the CO2 is the only one that we recommend. We've gotten this question so many times that we put all the rationale for this on our website that at ECRI.org/surgical_fires. It's all free there. And if you need to discuss and debate that with your facilities folks or with your local fire marshal, all the rationale for why only CO2 should be in each OR is presented there. Other questions?
Okay, we have another question here. If alcohol-based PrEP is a source of ignition for a fire, then why is betadine no longer used?
Well, the alcohol-based PrEP wouldn't be a source of ignition. That would be a fuel. The ignition source would typically be the bovie itself, but I understand the question. The issue of the bactericidal effect of alcohol versus the longer-term effect of betadine scrub or paint are something that really have to be just considered within your infection control department at the hospital. Alcohol kills immediately. Betadine is still used, but you still have to do the scrub and the paint. It depends on what's typically used at that surgical facility or ambulatory surgical center. It's the betadine is part of DuraPrep, which is also a flammable prepping agent, and betadine is povidone iodine, and what DuraPrep does is leave a film on the skin once it's dry, which is not flammable, and it has a latent bactericidal effect. So in my understanding, betadine itself, either the paint or the scrub, which are both water-based, are still being used. But you can get a shorter time in prepping the patient using the alcohol-based ones, recognizing, however, that you may need to have 3 minutes or more to let it dry. So it's really part of the overall process that your hospital, your surgical team has decided to use in regard to time versus fire hazard with alcohol-based preps. But betadine is still being used. Next question.
We have another question. It says here, I've been trained to use sterile H2O from the back table. Is that still okay?
Sure, it's still okay, but the question is, what are you using it for? If you're grabbing O2 from the back table to extinguish a fire, you're not going to extinguish that fire if it's burning underneath the drapes, because it's an oxygen-enriched drape or oxygen-enriched fire. In addition, surgical drapes are waterproof. So if you're pouring water on the top of a waterproof surgical drape, you're not wetting the underside. You're not wetting the towels on the underside. You'll see in the APS that video that sterile water was used to treat the burn, which was actually just red lipstick and a bunch of soot in the video. But the sterile water was poured on it after the burning materials were removed. So it's okay to use it, but that's not what you should first do in regard to trying to extinguish a fire. You need to get what's burning off the patient. Any other questions?
Okay, and I have another question here. What is a good way to achieve help from our senior hospital administration to prevent surgical fires?
Okay. I touched on this a little bit earlier, and getting them to understand that all the major medical professional societies, for the surgeons and the anesthesia professionals and the OR nurses, they are all committed to prevention. And you can get administration to understand that by showing them the APSF video. That's one way. And although rare, the adverse publicity for a hospital can be devastating and costly. And administration needs to endorse your hospital's initiative for the annual education on surgical fire training. There was a hospital where we investigated 3 surgical fires in 1 year. And for the third fire, they were doing a pacemaker implantation. And the fire was so severe that it even burned the dentures inside the patient's mouth. The CEO at the hospital was on vacation in the Caribbean at the time, and we had already provided recommendations for prevention of surgical fires at that institution. He stopped his vacation, came back to the hospital, and very firmly said to the surgical staff, if you all are not going to follow these recommendations, then you can leave now. And a lot of good came out of that in regard to what that hospital subsequently published. And within the nursing and anesthesia and surgical communities, that administrator came to understand a little bit too late that the stressing of the need for surgical fire prevention from administration is what was really needed at that institution. And they haven't had a fire since, as far as I understand.
It looks like we have one more question here. It says, what if a patient cannot remove a ring on a finger and during a colonoscopy they need to remove a large polyp with a snare?
Okay. ECRI Institute wrote the FDA standard on electrosurgical equipment. And having a ring on a finger during a colonoscopy, or in reality even during general surgery, does not present a hazard to that patient. You have to understand how the electrosurgical electricity actually works. It's different from what comes out of a wall socket or out of a battery. And ECRI Institute has never felt a great need to remove rings from a patient. In some cases, piercings certainly need to be removed depending on how close they may be to the operative site. But that would not present a hazard during a colonoscopy. This raises a similar question that frequently comes up, where should a timeout for surgical fire risk assessment be done in endoscopy suite, such as for colonoscopy? Because there's frequently pushback from the colonoscopists and endoscopists who, as the question begs, might be using electrosurgery inside the intestine. And we've said it's not that real necessary to do it in the endoscopy suite, that if you wish to do it, one way to get it done is to have the nursing staff in the endoscopy suite, through a formal protocol at the institution, make the assessment ahead of time and rather than having the surgeon involved in that. And if that assessment's done ahead of time and deemed to not involve a risk to the patient, then nothing else special has to get done.
Thank you, Mark. This concludes our webinar.